In this image-based presentation, I'm going to discuss some of the interesting renal ultrasound cases that we encountered in our practice. When you're doing a quick bedside renal ultrasonography, especially in a patient with acute kidney injury, it's very easy to mislabel any anechoic structure that you see in the renal pelvis area as hydronephrosis. Today, I'll go over such traps, including some of the normal anatomic variants that can mimic hydronephrosis. We'll start with a quick refresher of normal kidney anatomy and common sonographic pathologies we see. So each kidney consists of outer cortex and inner medulla that is organized into pyramids. And each pyramid opens into minor calyx, and minor calyces combine to form major calyces, and major calyces combine to form funnel-shaped structure that is renal pelvis, which continues as ureter. And it's also important to note that the cortex extends in between the pyramids, and these are normal and they are called columns of Burton. And the importance of knowing that these things exist is that sometimes they can get hypertrophied and can mimic a mass called hypertrophied columns of Burton. And the space here in between calyces is filled with fat normally, and that's sinus fat. As you can see in the pathology picture of the kidney, all this space is filled with fat. On ultrasound, kidney appears as a well-defined structure because it's encompassed by a capsule that is hyperechogenic, and the cortex, you can see it is hypoechogenic, and medullary pyramids, they are anechoic for the most part. Sometimes they can be just slightly hypoechogenic than the cortex. It also depends upon the hydration status of the patient. The well hydrated the patient is, the black the pyramids appear. And the sinus fat is the most echogenic structure inside the kidney, and the collecting system appears as a hypoechogenic structure. And it's pretty much similar to cortex in terms of echogenicity. And usually collecting system is not black unless there is hydronephrosis. And here you can see the transverse view of the kidney, pretty much same thing. It's well defined because of the capsule, and hypoechogenic cortex and medullary pyramids not very clearly visualized here. And you have echogenic sinus fat and the collecting system here. Here, whatever you are seeing here is this tubular structure that is anechoic, is most likely a blood vessel and not ureter, because ureter is rarely visualized unless there is hydronephrosis. So the first pathology, the commonest one, is hydronephrosis. This is why we are doing point of care ultrasound most of the time. So in this illustration, normal kidney looks like this with ureter, pelvis, and calyces that are concave here at the place where medullary pyramids terminate. And in the mild hydronephrosis, renal pelvis is the first thing to dilate along with the proximal ureter. And as the degree of hydronephrosis increases, which means there is more and more backflow into the kidney, then these calyces start to become convex. And once they become convex, they push the renal parenchyma backwards, and now you start to lose the architecture of the medullary pyramids. And as it becomes more severe, and you see more and more dilatation of the renal pelvis, and the cortex becomes thin, and you may or may not actually see any pyramids. And this is an example of mild hydronephrosis on renal ultrasound. Here you see anechoic structure that is dilated renal pelvis, but you are still able to see nice renal cortex and medullary pyramids. And this is moderate hydronephrosis, where here you can see the dilated proximal ureter also, and more dilated renal pelvis extending into the renal parenchyma, and calyces becoming little more convex. Some radiologists describe this as cauliflower pattern also, the convex architecture of the calyces. And as the hydronephrosis becomes severe, like pretty much now you cannot see any pyramids or any parenchyma, the cortex has become very thin, and the entire kidney is filled with urine. Next one is stone. Stones appear as echogenic foci, like you see here, and they are accompanied by acoustic shadowing. That's an important artifact that helps us to identify stones or any calcified structures. And you can also see twinkle artifact on color Doppler that may be useful in identifying small stones that sometimes may not have shadow, as we showed in the video one. So the next pathology is cyst. So cysts appear as well-defined anechoic lesions with thin walls, and they're almost always accompanied by this artifact, this posterior brightening that is called acoustic enhancement. And these cysts right here are simple cysts because you don't see any echogenic material inside the cyst, you don't see any septations inside them. And the cyst here is a complex cyst because you see septations here, which are echogenic structures inside the cyst. And here you can see calcifications. And if you closely observe, you can see the shadowing from these calcifications. So this is a good example of both acoustic enhancement and acoustic shadowing in the same picture. And this is how an empty bladder looks like with a Foley catheter inside it. The Foley catheter's bulb, which is filled with fluid, appears as a well-defined anechoic structure in the bladder. And because a catheterized bladder is like pretty much empty most of the times, you will not be able to appreciate the rest of the architecture of the bladder. So we'll jump into the real cases now. So the first case, here is a 58-year-old man who underwent renal sonography for mildly elevated serum creatinine. It was about 1.3 milligram per deciliter. So what do we see here? So this is a left kidney, and you see the spleen here and the kidney. The only thing that appears to be slightly off here is the outline of the kidney, where you see the bulge here in the lateral border of the kidney. And the question here is it a mass? And if you closely observe, this bulge looks like a camel hump. As you can see here, this is the dromedary camel with a hump, and this looks pretty much same as this one. And this is actually a normal anatomic variant called dromedary hump. So it is essentially a prominent focal bulge on the lateral border of the left kidney that is caused by splenic impression, and it can mimic renal neoplasm. And how do we identify this is dromedary hump? So the hump usually demonstrates same imaging characteristics as surrounding renal cortex, and renal pyramids do extend into this bulge. And if you are still in doubt, you can obtain technetium labeled isotope scan, and the dromedary hump will show normal uptake, whereas malignancy wouldn't. And also dromedary hump usually has the normal blood flow extending into the bulge, like you see here, the cortical blood vessels extending nicely, like one artery and one vein into the hump, so which is a normal pattern. So on the other hand, renal cell carcinoma almost always disrupts the outline of the kidney, and it's heterogeneous in echogenicity, and it may contain cystic areas, necrosis, and hemorrhage. That's why it appears very heterogeneous. In this first picture, you see there is a cystic area within this mass, and there are hyperechogenic areas and there are some hypoechogenic areas. So it's pretty much very irregular in terms of echogenicity. Here, this lesion for the most part, it is solid without any cystic areas, but it's very heterogeneous. So this is how renal cell carcinoma appears on ultrasound, while the dromedary hump is very uniform and homogeneous with normal vasculature. So the take-home point here is that dromedary hump is a normal anatomic variant that can be confused with a mass. Case number 2. Otherwise healthy 30-year-old male with a serum creatinine of 1.2 milligram per deciliter got a renal sonogram because he was a potential kidney donor, and we just wanted to rule out any major structural abnormalities. Here you see sagittal view of the left kidney. The prominent thing you would observe here is that there is anechoic lesion in the pelvis region. The question is it hydronephrosis? But probably not if you closely observe. This anechoic region is not in continuum. And you can also see it in the transverse view of the kidney. And you see there are two distinct anechoic structures that are well separated. So now we are left with two differentials. Is it cheliectasis, that is dilatation of just calyces without frank hydronephrosis? Or are these parapelvic cysts, that means the cysts that are pretty much like very close to the pelvis? But usually cysts are more well defined than this, so we are not sure. So what is the test that we do to differentiate these two diagnoses? We obtained a CT scan with contrast, which showed that collecting system is filled with contrast, and there are distinct hyperdense lesions here and here, which essentially means that these structures are not in continuum with the collecting system. So these are parapelvic cysts and not cheliectasis or not hydronephrosis. The take-home point from this case is that parapelvic cysts can mimic hydronephrosis or cheliectasis, and CT scan with contrast should be considered in cases where you need more clarity. So this is the sonogram, and as you know, hydronephrosis appears as branching and interconnected areas of anechoic nature or hypoechoic nature on sonogram. But you can see a well-defined structure here that is anechoic and that is not extending into the kidney. So you see a distinct medullary pyramid here pointed with an arrow, and you see the cortical thickness is well preserved. Similarly, in the transverse section of the left kidney, you see distinct medullary pyramids, and there is a bulge here that doesn't extend into the kidney. So this is not hydronephrosis. And we already saw from the CAT scan that this bulge is in continuum with the collecting system. So it's probably not a cyst that is originating from the kidney parenchyma. So what is it then? It is extrarenal pelvis. So what is extrarenal pelvis? So you know the normal pelvis of the kidney is here, a funnel-shaped structure, and it's surrounded by sinus fat on this side and renal parenchyma here. That way it doesn't bulge when it has urine in it. And what if this pelvis is outside the kidney? Now there is nothing to compress it. So when it's filled with urine, it tends to bulge out. But unlike hydronephrosis, where there is back pressure, here there is no back pressure pushing the fluid into the kidney, so it can balloon out. So the teaching point from this case is that extrarenal pelvis is a normal anatomic variant that can mimic hydronephrosis. And interestingly, in our patient, the acute kidney injury has completely resolved with treatment of hypercalcemia, but on the repeat sonogram, the extrarenal pelvis or this anechoic bulge persisted. Another case, a 64-year-old man with no known past medical history presents with serum creatinine of 10.5 milligram per deciliter, and initial sonogram was obtained, which was pretty much unremarkable except for mild prominence of the bilateral collecting systems, but there is no hydronephrosis. A CT scan of the abdomen and pelvis without contrast was obtained, which showed inflammatory and fibrotic changes involving the infrarenal part of the aorta and bilateral ureters, which indicates retroperitoneal fibrosis. And this patient underwent cystoscopy with bilateral retrograde pyelogram that revealed mid-ureteral narrowing. And here we showed one side of the picture, but bilateral ureter showed similar picture. And he was treated with bilateral ureteral stents, and surprisingly, his serum creatinine trended down to 1.3 milligram per deciliter over the next 4 days. Remember, he presented with a creatinine of 10.5 milligram per deciliter. So the teaching point from this case is that you can have obstructive nephropathy without any hydronephrosis, and you have to maintain high index of suspicion when you don't find any alternative cause for acute kidney injury. Case number 5. A 63-year-old man with a history of nephrolithiasis and neurogenic bladder requiring chronic intermittent urinary cath was admitted for acute kidney injury and urinary tract infection. His creatinine was 3.6 milligram per deciliter, with baseline being around 2 milligram per deciliter. And he was also having hypercalcemia with a serum calcium of 12.5 milligram per deciliter. And the initial bedside sonogram was pretty much unremarkable, except for maybe smaller kidneys, but it's hard to judge that with just one slice. And importantly, there were no visible stones or there is no hydronephrosis. And because of the abdominal pain, he also got CT scan without contrast, and which showed a 2.6 centimeter staghorn appearing calculus in the right kidney, but still there was no hydronephrosis on either side. So he was hydrated, and urinary tract infection was treated, but the serum creatinine was still trending up. So a repeat renal sonogram was obtained, and which showed mild hydronephrosis in the right kidney and a calculus. You see all this echogenic foci here with some shadowing, and when you see this discontinuous echogenic foci with shadowing, this probably represents a staghorn calculus. But the thing here is that why would a mild hydronephrosis cause acute kidney injury? We are also not sure about the degree of hydronephrosis here because of the prominent shadowing from these stone here. We obtained a radioisotope Lasix renogram, and it demonstrated complete obstruction on the right. Moreover, the right kidney had a differential function of about 70%, which means that was a prominent functioning kidney, and that explains acute kidney injury with unilateral obstruction. And a right nephrostomy tube was placed by urology, and look at the creatinine trend. The creatinine was around 6.1 when the tube was placed, and over the next few days it trended down to around 2.5, pretty much close to his baseline. The take-home point from this case is that volume depletion may mask underlying obstructive uropathy. Interestingly, it's estimated that over 30% of acute obstructions will be missed by ultrasonography in patients who are not specifically hydrated for the procedure. So it might be a good idea to hydrate patients unless there is obvious volume overload. And another interesting point is that in the study that reported highest sensitivity of ultrasound for the detection of hydronephrosis, that is 97%, patients were administered 500 cc of intravenous fluid prior to the scan. The next case, a 57-year-old woman presented with fever, abdominal pain, nausea for about 6 days, and lab showed leukocytosis and lactic acidosis, and the blood pressure was low. And the initial CT scan showed mild bilateral hydronephrosis without perinephric stranding or fluid collection. So she was admitted for sepsis, and she needed vasopressors. So exploratory laparotomy was performed to look for any bowel source of sepsis, but it was negative. And nephrology was consulted for acute kidney injury and possible initiation of continuous renal replacement therapy. Of course, we started CRRT, but renal ultrasonography was performed, which surprisingly showed these findings. There was definitely hydronephrosis with all these anechoic structures in the pelvic region in both the kidneys. And also, the important thing to note here is that there is some dirty debris here within the collecting system, and it makes the hydronephrosis appear as a non-continuous locculating structure. So what is this dirty echogenic structure? It's most likely pus in the collecting system, and it represents pyonephrosis. So immediately after noticing this finding, she underwent bilateral nephrostomy tube placement, and simultaneously her E. coli sepsis was treated. and after the placement of stents, within a few days, her renal function significantly improved, and she went home with near normal creatinine. So the take-home point from this case is that ultrasound can be more useful than non-contrast CT for detection of pyonephrosis, because you might not be able to give contrast for the CT scan always in the presence of renal dysfunction. Next case here. So this is ultrasound image of the native kidney in a patient with kidney transplant a few years ago. The etiology of the patient's end-stage renal disease was autosomal dominant polycystic kidney disease. We just wanted to get an idea of her native kidneys. And also, as you know, the risk of renal cell carcinoma goes high after 1 year of ESRD or transplant compared to general ESRD population in patients with autosomal dominant polycystic kidney disease. So what you see here is the liver. This is the right kidney, right native kidney with multiple cysts here. But what is this here? Is this renal cell carcinoma? This is a big mass. But wait a minute, it looks like something familiar to us. So is this really a mass? What does it look like? Doesn't it look like a transverse section of a kidney? So as you can see here, the right lower quadrant renal transplant is being cut in a transverse direction by the ultrasound beam, while it's cutting the native kidney in the longitudinal direction. And this is another case where you see urinary bladder very close to the kidney. It could be a pelvic kidney, or it's a transplanted kidney. So the teaching point or take-home point from these cases is that you should pay attention to the anatomy of the transplanted kidney. So the next case. So here we have a patient with oliguric acute kidney injury, and the ICU resident says, oh, we don't suspect any obstructive nephropathy because the patient has indwelling Foley catheter. Please come and evaluate for dialysis. Now we come and do a bladder scan and see what it shows. It shows this well-defined bulb of the Foley catheter and surrounded by hugely distended bladder. So what is the diagnosis? So this Foley catheter is not working. It's probably clogged by a clot or something. So you just need to flush the catheter, and probably there is no need to dialyze the patient. And similarly, there can be other circumstances where you see this bulb of the Foley outside this bladder wall. And then if you see a distended fluid-filled structure here, that could be a bladder if you put the Foley catheter in vagina in a female patient. Or sometimes you see a irregular fluid collection here outside the Foley. That might be pelvic ascites. So the take-home point from this case is that you can still have bladder outlet obstruction with indwelling Foley. Don't assume things. The last case, here we have a 34-year-old otherwise healthy man who complains of back pain, and he had history of kidney stone several years ago. We obtained a renal sonogram. So what does it show? So what do these arrows point to? So the medullary pyramids, which are normally supposed to be anechoic or hypoechoic, here they appear to be very prominent and hyperechoic. See? So these represent medullary nephrocalcinosis. But surprisingly, this patient did not have any renal tubular acidosis, no hypercalcemia, and serum creatinine, PTH, vitamin D level, all were within normal limits. Only thing that was abnormal was his urine calcium excretion was significantly high at 624 milligram per 24 hours. So he has idiopathic hypercalciuria, and he was treated with thiazide diuretics and supportive care. So the take-home point from this case is that idiopathic hypercalciuria can cause medullary nephrocalcinosis. So thank you, and I'm looking forward to coming back and discussing more interesting cases in future.